Sahin? Sahin? Just try and keep them.
Okay, so let's start up again. Welcome back from lunch. This is the third session. We're very happy that two speakers. Dr. Andy from the HSE in Limerick is going to start us off. And Anne speaks for about 15 minutes. And that should leave about 5 minutes for questions and answers at the end of Anne's presentation. And then we're very happy to have Professor David Madden from UCD. And David will speak for around 25 minutes. And again, that should leave about 5 minutes at the end of his slot for questions and answers. So maybe we'll kick it off. Anne, the floor is yours.
Good afternoon. Hope you're having a nice lunch. As you said, I'm Andy. I'm a public health doctor from Limerick, and my only claim to fame really is that I got mentioned in Professor Cawley's talk this morning. Go me. And the reason I got mentioned was because I was the lead researcher on this study, but I wasn't the only researcher. And Professor Ivan Perry was the PI, Kieran O'Neill, and his internationally renowned team of health economists, who were our health economists. Anthony Staines led a group in DCU. We had Professor Frank Key in Queen's in Belfast, Linda Sharp from the Cancer Registry, Kevin Belanda from the Institute of Public Health, and the funders for the study were Safe Food, and I particularly want to thank Dr. Cleona Foley-Nolan for her support. And at this moment I'm going to digress and tell you a short story. When I was a medical student, I decided that cycling wasn't really for me, especially in Cork, which is renowned for its hills. And so I decided to borrow some money and buy a car. So I went and got myself 4 driving lessons, bought a car and drove to Cork. And luckily, in the short time after I arrived in Cork, I only had one accident. And that was I bashed into a young doctor at the time who was driving a very nice little Nissan Micra or something like that. And the doctor in question was Dr. Cleona Foley-Nolan. Whom I didn't know at the time, but anyway. And but I learned a valuable, she was very decent about it all, and I learned a very valuable life lesson, which is watch where you go. And on that, we've been watching where we've been going with overweight and obesity for a long time, and this is where we're going. For those of you that are old enough to remember Lowry's Matchstick Men and Matchstick Cats and Dogs, an artist called Blower has done a redo of this in the current society, or maybe what will be society very shortly. And this is the picture in figures. The picture is that, according to the Tilda data, 84% of men over the age of 50 are either overweight or obese. And you can see that for both men and women, and both the north and the south, these figures are absolutely startling and quite shocking. And of themselves, most of what I have to say here has already been said, but I'll just put some of it in picture form of itself. Obesity wouldn't present a problem if it wasn't for the fact that it causes a lot of comorbidities, a lot of illnesses. And we're just going to quickly run through some of those. Looking here at cancers in females. The blue blocks represent the increased risk for overweight women, and the red blocks for obese women compared to normal, which is the 0 line. And you can see for a number of cancers that there's a very largely increased risk. Same for male cancers. And if you look at that one there for large bowel, and then realize that large bowel cancer is one of the commonest cancers, you can see that this is a huge amount of illness in Irish society. Looking at chronic diseases then again for men, you can see osteoarthritis, back pain, stroke, hypertension, coronary heart disease. They're all, it's very significantly increased. And for women, again, some very common illnesses like hypertension, stroke, coronary artery disease, chronic back pain, all very much increased in both the overweight and much more again in the obese. I took diabetes out of those slides because it was so big, it made everything else look tiny on the slide. So just the massive, you're 12 times more likely to get diabetes if you're an obese female, if your BMI is over 30. You're 6 times more likely if you're an obese man. And overweight people are also at a very significantly increased risk. So the first thing we did as part of this study was looking at the literature. And what we looked at was the literature up to the end of 2010, I think. And the overweight and obesity account for somewhere between 1 and 9% of healthcare costs. Now, I know somebody quoted a figure this morning of 20%, a more recent figure from the United States. In Europe, we see these costs are generally between about 1 and 4 or 5%. And in the United States, they start at 5, and that would have been back in the 1980s, I think, definitely the 90s, and going way up. The non-healthcare costs generally are as much or more again. The studies that showed them show that they comprise between 51 and 84% of the total costs of obesity. And as has already been mentioned, with increasing BMI, costs increase. So the heavier you are, the more likely that your costs will be high, and this is particularly true for the very obese. So what we looked at, we looked at healthcare costs, which were inpatient, outpatients, general practice and drugs, and non-healthcare costs, which was lost production due to time off work, due to overweight and obesity-related illness, and due to premature mortality. So people who couldn't be at work because they were sick, because of obesity-related illnesses, or because they had died. The methods we used were a mixture of methods. Originally, we had looked at the literature and thought that a bottom-up approach would be the best, but it's very much dependent on the data that you have available, and our survey data just wasn't particularly robust, and so we ended up doing a mainly top-down approach and supplemented with bottom-up. So the top-down approach is a prevalence-based approach. You take the large cost data sets. We have the HYPE data, the primary care reimbursement data, and then you calculate population attributable fractions using relative risks for the various illnesses and the prevalence rates for overweight and obesity, and you apply these population attributable risks for each illness to the cost data. When we calculated them by age in 5-year age groups from 18 to over 80, and by gender, by male and female. So we calculated a very large number of population attributable fraction for a large number of conditions. For the bottom-up part of the work that we did, we used cross-sectional individual level data from Sloan, from Tilda, and from the Northern Ireland Health Survey, worked out the probability of using a service, then the additional probability of using the service if you had an increased BMI, controlling for various confounders. We didn't control for age squared. I'll go home now. So, as I say, we used Sloan, Tilda, the Northern Ireland Health Survey to map healthcare usage by BMI. We used HYPE, and the HYPE is the Hospital Inpatient Inquiry, which is the Irish Hospital Inpatient and Day Case data, and the HACE is Hospital Inpatient Statistics, is the equivalent in Northern Ireland. We also used the drugs and prescribing data from the Primary Care Reimbursement Service in the Republic of Ireland and from the Business Service Organisation in Northern Ireland. For non-healthcare costs, we looked at illness benefit data in both jurisdictions. There were a lot of issues around this data, which I won't really go into, but it wasn't straightforward. We also did a bottom-up approach, looking at the Sloan data and the Northern Ireland Health Survey, and again there were issues around that as well. For the premature mortality data, we only had one way of looking at it, and that was from the top down using the CSO mortality statistics from both jurisdictions. So for the Republic of Ireland, I've just put up the full list of results there. It's quite small, so apologies. And the ones highlighted in bold are the ones that we used for our headline figures, and There were a number of reasons why we chose particular figures, one over the other. Some of it was for comparability, because we wanted the study to have the same, across the jurisdictions, we wanted to have used the same type of approach, and we couldn't always use the same approach in both jurisdictions. So where we could find a common approach, then we used that result. And sometimes we only had one way of looking at it, so we had to use that result. So you can see that there were some, the GP costs were only looked at by a bottom-up approach, and it's, I think, quite a low figure, and I think probably in reality that figure is a bit higher. Inpatient and day cases we could look at both ways, but we were using, for the cross-sectional analysis, for the bottom-up, we were looking at the SLAN data in the Republic of Ireland using self-reported BMI. And there were a number of issues, again, around that. Also, I think the robustness of the actual questions, you know, they weren't designed for us to work out the cost of obesity from them. And I think this presented some problems as well. The wording of the questions was poor in relation to this particular study, not in general, they were fine. So, looking at that, I'm going to just move on. The indirect costs again. We looked at indirect costs in a number of ways. We did cross-sectional analysis using human capital approach, using friction cost approach. We did a top-down using human capital and friction cost. And in the end, we went in both jurisdictions looking at a top-down approach on the social welfare data using a human capital approach. And the reason we chose a human capital approach is that really in the literature, that is what is generally reported. Northern Ireland, again, a similar set of results, but for some of the cross-sectional analysis, because it's quite a small data set for Northern Ireland, we could not, produce a result, and therefore we had to outrule using this part for the Republic, because we wanted to have it the same. We just went with the results that we could. So, our headline results, I think most people are aware. In the Republic of Ireland, the cost of overweight and obesity combined 1.16 billion per annum. I personally think that's an underestimate, and I think that, that if we repeated it in a few years when we have better cost data, we might find that it is quite a bit higher. For Northern Ireland, that was €500 million, it's €500 million Irish euros, converted to PPP 2009 euros. So in the Republic, the direct costs represented 38% of total healthcare spend. No, sorry. In the Republic, the direct costs represented 38% of the total costs, and the indirect costs were the 62%, and 2.9% of healthcare spending, and a very similar figure in Northern Ireland. The main drivers of costs, it was interesting, the direct healthcare costs, cardiovascular disease, type 2 diabetes, colon cancer, stroke, gallbladder disease. And if you looked at the slides back along, showing the increased risk, stroke, colon cancer, cardiovascular disease, they weren't the big tall ones, but they're very common illnesses. And so even though the increased risk for these might be a little bit less than it is for things like gout and other illnesses, because of the volume of disease and the volume of chronic disease, these were very high drivers of cost. For absenteeism, it's a completely different picture. It was all musculoskeletal disorders, or it was mainly musculoskeletal disorders driving absenteeism. So musculoskeletal disorders in the overweight and obese are the main cause of absenteeism in both the Republic and Northern Ireland. So the main drivers of cost for premature mortality, then again, you're back to the original ones: cardiovascular disease, colorectal cancer, and type 2 diabetes. So the recommendations from our study, again, most of this has been said already. Urgent public health action is required, and we need a population health-wide prevention approach. I think it's important that we have that we have a coherent message. I think it's important that we have a simple message, and I think it's important that as professionals that we agree a message and then we shout it as loudly as we can, because there are all sorts of competing voices and competing interests coming from industry and various other places, and so we need to really get our message out there. We need targeted action, as was mentioned earlier, for the very obese. I think you find that it's, trying to bring about behaviour change at that point is unlikely to make a difference. Workplace interventions are needed to deal with this problem of musculoskeletal problems and absenteeism in the very obese. And then we need to extend regulation of the food industry. We've already got a lot of regulation around microbiological safety and chemical safety of our food, but there is no real regulation around the safety for human health and well-being, and I think that needs to be factored in. And there does, of course, need to be significant investment in research to find the things that work in an Irish population and to implement them. So the full list of recommendations is available at this web address, and that's it.
Thanks very much, Jan. So let's open it up to the floor. Any questions?
Hello, David Robbins, my name from UCD. Thanks very much. It's a very careful paper. I remember doing a similar exercise for the cost of smoking back about 10 or 11 years ago, so I kind of know what you went through. I suppose... I also remember the Larry picture, actually. It's the year I did the legal cert, that song was number one. Anyway, I suppose one thing though, these exercises are difficult. They're difficult issues to get your head around, because I was talking with John Cawley about this at lunchtime. One of the things to think about is, imagine the counterfactual that we were able to eliminate obesity and we're able to cut it in half. Well, what would happen then? Well, clearly we'd cut in half probably most of those healthcare costs that you've mentioned up there. But then people would live longer, and they'd probably have other healthcare costs down the line, and they'd have costs of looking after the elderly. And it's possible that those two costs, even allowing for discounting the future costs, would balance out. Now that's, in a sense, it's a very narrow and an unpleasant way of doing this arithmetic. But of course the benefit would be that those people would live longer, so they would have the benefit of all those extra years of life. So I just think with these cost exercises, I think it's, as well as looking at the costs, it's important that we know what the costs are, but we also think about what the benefits would be if we were able to reduce the condition. I think that's maybe even a more important part of the equation.
Well, I think actually, I can't remember exactly what your question is, Siobhan, but Siobhan Jennings here somewhere. She has, we're trying to put together a research question asking that. She's going. So yeah, I mean, as a healthcare professional, I cannot recommend that we let people, die sooner to save costs. And I mean, there are all sorts of benefits to society of having a healthy population, and there are benefits to the economy of having a healthy population beyond just the physical, and I think that's important too.
I'll abuse my position as chairman.
Oh, please do.
Just a follow-up question, because one of the big items was $500 million on premature mortality, which I think follows on from what David was saying. How did you calculate that? Because if people die early, well, they're going to die at some stage, so it's going to be cost. And if they live longer, there's a pension that has to be paid out by the state. So are all those things taken into account, or is that possible at all?
Okay, all right. How we measured it, first of all, how we worked out who has died from overweight and obesity is I explained that by working out the population attributable fractions and looking at things like cardiovascular disease, cancers, the ones that we included, which were about 10, and all the other, stroke, 10 people don't particularly die from hypertension, stroke, cardiovascular disease, diabetes, all these things. So we worked out what proportion of people died from these conditions, and then we knew their ages. And so then we applied just the average wage to those people up to the age of 75, and after the age of 75 they got 1/3. Kieran, help me here if I'm right. They were assigned 1/3 of the average age because it was considered at that point that you were no longer earning the same kind of money. But we didn't want to not value people at that age because, you know, there's a whole host of benefits that retired people bring to society in terms of volunteerism, minding family, children, allowing their children to go to work and contribute to the economy. So that was how we valued them. Does that answer your question?
Yes, thanks.
Right.
We have time for a couple of more questions. Microphone is just coming.
Is there, is €1 spent here in Ireland on obesity the same as €1 spent elsewhere? I mean, is there a type of, Big Mac index or?
When you mean spent on obesity, do you mean spent on healthcare?
Healthcare, yeah.
Well, the costs of healthcare vary from country to country, which is the value of doing these type of studies, I won't say it's questionable, but it is. There are differences from country to country in terms of the cost of their healthcare, and in Ireland, in the Republic of Ireland, we have particularly high costs of healthcare. So some of that became apparent just in looking what we were looking at, especially around drugs costs. In Ireland, we spend an inordinate amount of money on drugs because there's very little control on what people can prescribe, and basically the HSE will just pay for anything that comes across its path, and so we have a massive drugs bill. But I think probably no is your answer, unless anybody else can.
Okay.
You done?
Thanks very much. Second speaker is Professor Dave Madden from UCD.
Hello everybody, and once again I'd like to thank Brendan for inviting me to talk today. The title of the paper is The Poverty Effects of a Fat Tax. Oh, I spelled effects wrong. Oh well. The Poverty Effects of a Fat Tax. And this is a guy called Mike Rayner, who I worked with a little bit over the last year or so, and he's got terribly agitated when people use the phrase fat tax. He said they're not fat taxes, they're health-related food taxes. Look, you get the nice little, it sounds good, nice soundbite fat tax, so that's the phrase that I used, although I apologise for it in the early part of the paper upon which this talk is based. So a lot of the papers we've heard this morning, particularly John's paper, were quite wide overviews of the area of obesity and policies we might take to address obesity. What I'm looking at then is a very particular type of policy, which is a fat tax, and I'm looking at a very particular subset or sub-issue within that particular policy, which is the distribution or the poverty effects of a fat tax. So this paper is not about whether I think a fat tax is a good or a bad idea. There are pros, there are cons. It's quite a complex issue. This is really more an exercise in positive rather than normative economics. So I'm trying to tease out, if we did introduce a fat tax, what would be the distributional implications of it, okay? So we're looking at how we measure the poverty impact of a tax change, and in reality, actually, this is really a paper in public economics rather than a paper in health economics. I just happen to be applying it to a tax change, which has become quite topical in health economics. The particular approach I'm going to use is what's known as consumption dominance analysis, which is really a way of evaluating a tax change while putting relatively few restrictions on the the type of social welfare function or social evaluation function we use to make such evaluations. I'm going to apply it to Irish data from the Household Budget Survey of 2009-2010. That's the most recent HBS that we have. In the second part of the paper, this is really taking a hostage to fortune, because once you come up with a number, people fixate on it. And I was talking to somebody from the Irish Times this morning, and I've just got this nightmare scenario that there's going to be a headline tomorrow. Madden says it costs this, and everybody comes up and kind of says, sort of holds you to that. I do try to measure the impact of the tax change in terms of the impact on poverty using a money metric, just to give us some idea of what would be needed to be returned to poor households to compensate them for the effects of a fat tax. So this is a brief enough presentation. There's lots more bells and whistles in the actual paper itself, which is coming out in Health Economics, and there's a non-gated version of the paper, excuse me, on the UCD research site. Okay, so what type of tax changes are we going to look at? Well, we can look at a tax change in isolation, so we increase the tax on sugar-sweetened beverages, or we increase the tax on fatty goods, or whatever. What I also want to look at is the impact of a revenue-neutral tax subsidy package, so that we introduce a fat tax on a selection of goods, but we also provide a subsidy on another subset of goods, which are, let's call them, good foods. And this would be revenue neutral, okay? So that, when economists analyse tax reforms, they like to do so on a revenue neutral basis, because then you don't really have to worry about what happens to the revenue. So this would be a revenue neutral basis. And one of the other advantages of that is that a lot of the time when you talk about fat taxes, people's response is, oh no, not another tax. The government they're not doing this for our health, they're just doing it to get in more money. And they may well be doing that. But looking at it on a revenue neutral basis kind of parks that issue to one side. Okay? So when we're trying to evaluate the impact of the tax change, we use what's known as a social evaluation or social welfare function. So that'll be standard approach in welfare economics. And basically what we do is we use a result called Roy's identity. Now Roy's identity is a result which tells you what the welfare impact, or gives you a first order approximation of the welfare impact of a price change. And by a price change we mean a tax change. Okay, so we can estimate what the effect will be on each individual household, and then we aggregate that effect across all households. Okay, I say we use some form of aggregation because we can aggregate it in a number of different ways. We could aggregate it, just simply add them all up, or we could choose to put a higher weight on the costs to poor households as opposed to rich households, if we have some idea of inequality aversion that we want to build into our social evaluation function. Now, one of the difficulties about using social evaluation functions, or using this approach to evaluate tax changes, is that the results you get might be specific to the particular social welfare function or social evaluation function that you use. So that's why a lot of the recent research in the area in the last 10 or 15 years has looked for what we call dominance results. And by a dominance result, we mean a result which would be passed, if you like, was passed as a welfare improvement by a wide range of social evaluation functions that obey some generally acceptable properties. Now, the particular type of social evaluation function I'm interested in looking at here is a very peculiar one, in that it's a measure of poverty. And by a measure of poverty, we're only concerned about what happens to those people who are below the poverty line. So I'm not worrying at all about the impact of the fat tax on people who are above the poverty line. Okay, essentially we don't care about them. So it is a very peculiar type of social evaluation function, but it's the one I thought might be interesting to look at. And because it's a dominance approach we're trying to take, I look at it for a wide range of poverty measures and also for a wide range of poverty lines, because clearly where we draw the poverty line can be important. So it's nice to know if our results are sensitive or not sensitive to where we draw the poverty line. So I'm going to use the following terminology, what we call pro and anti-poor tax changes. So we define the poor as all those people who have an income below the poverty line Z. Now, in actual fact, I'm going to use a measure of expenditure as the measure of household resources, but I'll use the income term for the moment. So we know that a tax increase is not good news, okay? So a tax increase will be relatively anti-poor if it harms the poor by a greater proportion than the non-poor. So if it has a greater proportionate effect on the poor than the non-poor, then the tax change is relatively anti-poor. Similarly, it's relatively pro-poor if it harms the poor proportionately less than it harms the non-poor. We have a similar definition in terms of the absolute change, but I'm not going to look at absolute changes in this presentation. We're just looking at the impact of the tax in a relative sense, and if you like, in terms of the fraction of the weekly household budget. Okay, here's a bit of notation, but what I really just want you to concentrate on, is this a pointer, is it? Brendan, is that a pointer? Yeah, but I can't. What do I? All right, there, right? So that's the expression for the consumption dominance curve. So we calculate it by calculating the consumption of the good, we call it good K, XK, right, for each household, and we divide it by the average consumption across all households. Okay, so we get an observation for each household, and we can draw out the curve as we go across from poorest households to richer households. That's the consumption dominance curve of order 1, and then the consumption dominance curve for order 2 is just what we get if we just add across the distribution of the consumption dominance curve of order 1, and similarly the consumption dominance curve of order 3 is what we get when we integrate across the consumption dominance curve of order 2. But we're mostly going to look at order 1. I'll explain why the orders are important in a minute. Okay? Now, this is the central result that we're going to use, and once again, it's not that complicated actually, despite the fact that the notation might look a little bit tricky. I'm going to have to point this out. So, take a look at this expression here. That's the fraction of the consumption of good K divided by the average consumption of good K minus the poverty line divided by the average level of income. Okay? So if this expression, you get an observation like this for every household. As long as this expression is positive, okay, then the tax increase will be relatively anti-poor because it's hitting people disproportionately. It's hitting a good which they disproportionately consume. That's for order 1, and then we just take the intervals for higher orders. Now, what is S important about? S indicates, if you like, the sensitivity which we place upon changes in poverty at lower parts of the income distribution, or lower parts of the poor household. So a value of S equal to 1 means that reducing poverty for the richer of the poor household, if you like, a household just below the poverty line, that's considered as good in terms of social welfare as it would be to reduce poverty for the poorest household. If S is equal to 2, we place a higher weight on reductions in poverty for the very poorest households. S equal to 3 is a really tricky one. It says, I won't even bother S equal to 3, we're just looking at S equal to 1 and 2, okay? We're going to evaluate this consumption dominance curve over a range of what I call plausible poverty lines. Now, what I mean by plausible poverty lines is the following. The typical definition of the poverty line, which is most frequently used, is 60% of median income or median expenditure. Okay, that's the official EU poverty line. So I'm going to look at the effect of this VAT tax on incomes from the poorest household up to twice that poverty line. So I'm covering a very wide range of poverty lines, and what I think any reasonable person would include. Sorry, I don't think any reasonable person would think that somebody who had 120% of median income would be considered as poor. Okay, what about when we have a tax and subsidy change together? Okay, similar type of approach, and the definition is if we were to subsidise good I and tax good J, all right, in a revenue neutral way, then we calculate this expression here, which is we find the consumption dominance curve for I minus gamma times the consumption dominance curve for J. If that's positive, then the VAT tax is relatively pro-poor. So what's gamma? Gamma is something that I'm actually going to kind of assume away that has a value of 1. But what it reflects is the differential efficiency cost of raising revenue from taxing good I as compared to good J. It depends upon the own price elasticity and the cross price elasticities of good I and good J. Broadly speaking, a good with a relatively high own price elasticity, in other words, that's very sensitive to price change, will have a higher efficiency cost. Now, the bundles of goods I'm looking at are pretty similar, so I'm going to assume that this gamma parameter is equal to 1, in other words, that their elasticities are pretty much the same. Okay, the data I'm using comes from the 2009-2010 Household Budget Survey. It's got detailed expenditure data. It's what's used as the basis for constructing the Consumer Price Index. There's just under 6,000 households, and I use total expenditure as the measure of household resources. And similar to, I think, Brendan and John's paper this morning, we apply equivalent scales to take account of the fact that households differ in terms of size and composition, so we try to look at them all on a level playing field, if you like. And the equivalent scale I use is a very simple one. I simply divide by the square root of family size. Now, here's an important point. Because the HBS presents data on a household basis, okay, each unit of observation is a household. But households will differ in size. Even after we've adjusted by the equivalent scale, you have a household of one person, you'll have a household of maybe 10 people. Okay? Now, in terms of poverty, I think it matters more for society if we were to lift a household of 10 people out of poverty and a household of one person out of poverty. So we reweight each household according to the number of people in it, so that we're effectively looking at this issue on an individualised basis. Now, that's important because we're looking at food and we're looking at sugar-sweetened beverages in the approach we're doing here. And they tend to be disproportionately consumed by large families with large numbers of children. So it's important to apply the per person weights here. And we also apply the standard weights for differential response, etc. Okay, what goods are we looking at in terms of the tax? Well, there was a paper by Moore in the British Medical Journal, I think about 13, 14 years ago, and he looked at the sources of saturated fat in the UK diet. And he came up with this conclusion that just under half of it came from the following goods: whole milk, cheese, etc., etc. So what I did was I took categories in the household budget survey which were as close as possible to the categories that Moore listed, okay? And I then added in one or two others which I thought would be plausible candidates for a fat tax, like chip shop purchases, takeaways, and purchases in fast food outlets. They're already subject to VAT, but you could also put on an extra excise duty if you wanted to. So I'm calling these bad food, okay? Now, in terms of the tax subsidy package, I've got to look at good food, so I'm just defining fresh fruit and vegetables as being good food, okay? And I also take a look at what would happen if we were to look at sugar-sweetened beverages. The reason being that this was the specific policy which was examined and may still be under examination in the Department of Health. Okay, just a few further observations before I present some graphs to you. The choice of foods into good food and bad food at the margin is clearly going to be arbitrary. Okay, and if a fat tax was ever going to be introduced, there would be massive lobbying for different groups to make sure that their food wasn't to be included. There was the big debate over a Jaffa cake. Is it a cake or is it a biscuit? Because there's differential tax on cakes and biscuits. I think it's a biscuit myself, even though it's called Jaffa cake. Anyway, the main point here is to show the methodology, right? I also carried out the analysis not including full fat milk, because a lot of people think full fat milk is good for kids when they're young. So, but the qualitative results, very, very similar. Here's an important assumption. I'm assuming that 100% of the tax incidence and subsidy is passed on to the consumer. Okay, so if the government increases the tax by 10%, the price the consumer pays will go up by 10%. The same with the subsidy. That's a heroic assumption. Okay, in the case of taxation in particular, if we lived in a perfectly competitive world, then yes, taxes are passed on completely to the consumer. When we live in a world where we don't have perfect competitions, where the food industry is a bit oligopolistic, then the pass-on rate can be either above or below 100%. So we tend to stick with 100% as a working assumption. Once again, I assume that the differential efficiency cost is the same for good food and bad food. That might not be accurate in the case of sugar-sweetened beverages. I think the elasticities for those goods are a bit higher than they are for other foodstuffs, but I'm going to run with the gamma equals 1 assumption. Revenue neutrality means that if we're to have it approximately equal, it could well be that the percentage tax increase will be different because one set of goods might be a bigger fraction of the budget than the other, but that's just a detail. And then the poverty line, we go from 0 to 120% of median expenditure. Okay, I'm going to skip through the angle curves. Bump, bump, bump. Oh, right. Okay, so here's the first picture. So this is the relative CD curve for bad food at S equals 1. So along the horizontal axis, I've got normalized expenditure. So 1 refers to the poverty line, 60% of median income, and 2 refers to twice median income. Okay? Now, you can see that this graph is above 0 for pretty much every observation. What that tells you is that if you impose a tax on the bad foods, it will be anti-poor. relatively anti-poor. Why? Because these foods constitute a greater proportion of the weekly expenditure of poor households rather, than they do for rich households. There's no rocket science here, like John said earlier on. Wow, I'm telling you that we all know that poor families spend more money on food, so therefore it's hardly surprising that a tax on food will bear disproportionately upon them than upon better off households. Here's the same curve for good food. We see a lot of spikes at very low levels of expenditure. That may well reflect measurement error. When I did this analysis first, I trimmed the data of the bottom and top 1%, because I was worried that measurement error typically is most egregious at the extremes of the distribution. And the referee for health economics said, no, you've got to put them back in. So I put them back in. That's I think why you get those zigzags. But nevertheless, it's above zero for all the range of households. So good foods, if we were to tax fresh fruit and vegetables, that would also be relatively anti-poor. Sugar-sweetened beverages, the same effect. Okay, it's above zero for all reasonable range of households. Okay, but that's, I think, not necessarily the interesting analysis. What about the difference? Here's the CD diff curve between good food and bad food. Now remember the way I defined this. If this is above zero, okay, then the tax combination is pro-poor, okay? Poor households will benefit. Here I've got to use my zapper again. So this, I'll say, so for households right the way up here, it's above zero up to about here, then it starts hovering around zero. So at about for all households up to 60% of the poverty line, the tax subsidy combination would actually make them better off. What they lose on paying extra for bad foods, they gain on getting their good foods cheaper. But once we get to about 60% or 70% of the poverty line, it goes below zero, it hovers up and down, and then it kind of gradually trickles away. So we don't have what's called poverty dominance, because for poverty dominance, we need that curve to be above zero for all poor households. And we can see that it's a little bit below zero for some poor households. But it's not that far below zero, which means that the poverty effect is pretty minimal. Okay? What about the CD difference curve if we put a higher weight on improving the situation of the very poorest households? What we find is that the curve is above zero for a longer range, up to about 1.2 times the poverty line. If you were happy that 1.2 times the poverty line is a reasonable range, then you could say that this policy would be poverty improving for all poverty indices that are sensitive to the poorer households. But beyond about 1.2 times, it goes below zero. So if you believed in a wider range of poverty lines, then you wouldn't have what we call poverty dominance. And this is the same graph for looking at the combination of subsidising fresh fruit and vegetables and taxing soft drinks. And it's a similar enough situation. It starts to go down below zero at about the poverty line. And the second curve, where we have the greater sensitivity for poorer households, it starts to go below zero at about 1.3, 1.4 times the poverty line. Okay, the story so far. The fat tax on its own is not poverty efficient. The burden falls disproportionately on the poor, and this would be true for pretty much any food-based tax. But if we can implement a revenue-neutral tax subsidy mix, then the effect would be either pro-poor or else pretty much poverty-neutral for a certain range of poverty lines and indices. Now, I've talked about the tax subsidy mix, and one way we could think about this is that we tax the poor households with the fat tax, and then we compensate them by subsidising the other food. There's another way of looking at this. We could tax them with the fat tax, and then we could subsidise them by giving them a lump sum compensation amount. That's another way of looking at it. So what amount would we need to give to compensate poor households for the poverty effects of the fat tax? So can we evaluate these poverty effects, if you like, in a money metric? Now, to do that, I've got to move away from the dominance analysis and use a specific poverty measure. So the specific measure I'm using is, I'll run through this, I'll skip over this slide, it's the P-alpha class of Foster, Greer and Thorbecke. And let's just go down to this is the important one here, okay? So, in a paper, 1988, Tim Besley and Radley Campbell showed if you were to apply a tax change of 10% on bad food, if you like, okay, the change in this poverty index would be equal to 0.1, that's the 10% times the average expenditure of the poor household on the good, divided by the poverty line, multiplied by H, which is the fraction of households that are poor. It's the headcount index. Now this P1 index is a particular poverty measure. It's known as a poverty gap measure. And intuitively, the poverty gap measure summarizes the amount of money which the government would need to eliminate poverty. So think about the extent to which every household is below the poverty line. Every poor household will be below the poverty line. There'll be a gap for that household. So if we added together all those gaps for the poor households, right? That's what gives you the P1 poverty measure. So the P1 poverty measure tells you how much money you'd need to give to those poor households to bring them all up to the poverty line. So what this measure is going to do is it's going to tell us the change in that poverty measure when we apply the 10% tax on bad food. And running through the numbers, what it suggests is that it's about 0.073% for bad food, which would give a figure of approximately 28 million euro in 2009 prices. So that's what the government would need to give back to households to compensate them for the fat tax on bad food. If we look at the sugar-sweetened beverages, because sugar-sweetened beverages are such a smaller fraction of the weekly budget than those list of bad foods I gave you, the money which would be needed to compensate for a 10% tax increase is a good bit lower. It's just below 4 million. What about the change in P1 of the tax subsidy mix? That's the formula, but the two figures to look at are 0.16 and a reduction of 0.08 million. Now, given the degree of approximation, these are basically zero. In other words, that if we were to introduce the tax subsidy revenue mix, the effect on poverty would be pretty much zero. Okay. Points to note. Okay. In terms of evaluating, excuse me, the effect on households of the fat tax, I used that result which I called Roy's identity. And that's a first order approximation. It assumes that households do not substitute away from the dearer goods. Now, in all probability, if you were to increase the price of full fat milk or the price of some fatty goods by 10%, some people would switch away from them, okay? And so therefore their welfare loss would be less because they'd have moved away from the more heavily taxed goods. Now, I'm not allowing for that effect. So to that extent, the first order approximation I use is an overestimate of the welfare change, and it's an overestimate of the impact on poverty, okay? However, when we're looking at the amount of money we need for compensation, I'm assuming that the government is able to perfectly target those people who suffer from the fat tax, those people who actually consume the fatty goods, those people who actually consume the sugar-sweetened beverage. Now, of course, we know that below the poverty line, there's lots of heterogeneity in households. Some will consume loads of fizzy drinks, some will consume no fizzy drinks, okay? I think it's pretty impossible for governments to costlessly identify those households. So the chances are the way that they'd have to do would simply be to give a lump sum to everybody, okay? So therefore, the number I've quoted here, which assumed perfect and costless targeting, that number of 28 million, that's probably an underestimate. So that 28 million number, which I pray don't fixate on, okay, but that 28 million number has got a bias both of an overestimate and an underestimate. So if they were to cancel out, and the literature suggests the overestimate is about 10%, then the number here might be useful or near enough approximation to what actually happens. A couple of other things to bear in mind. I'm just about to finish now. The particular type of evaluation I've looked at here has just looked at the impact on poor households. I haven't looked at the impact on non-poor households, okay? So there will be a welfare effect on non-poor households, and I'm not including that in my evaluation, okay? But there may also be health benefits. Like, the whole point of this is not to raise revenue. The whole point of this is to try to presumably encourage people towards what we would think would be a better diet, and therefore that there would be health benefits. So if those health benefits were concentrated amongst the poor, then that would be a good thing. Okay, so the conclusion. I've shown you what I think is a useful methodology to use to evaluate if a tax change, any tax change actually, not just a fat tax, any tax change is pro or anti-poor. I've also shown how we can get some estimate of the quantitative effects of that tax. What the results here suggest is that pretty much any fat tax on its own will be relatively anti-poor, but that it is possible, or it should be possible, to put together a tax subsidy mix which would not be anti-poor. The quantitative poverty impact of a fat tax clearly depends upon a number of factors. It depends upon the size of the tax increase, depends upon what goods it's imposed upon, depends where we draw the poverty line. But using what I think are plausible estimates, the numbers that I've come up with here of just under 30 million, in the context of the overall budget, doesn't appear to be an insurmountable barrier. So if you were to take any message from this talk, if I could do it in a tweet or a haiku, I'll do it in 17 rhyming syllables. If I could give you the message, it would be, leaving aside the pros and cons of a fat tax, the distributional impact, to my mind at least, is not a barrier to the introduction of fat tax. There are other issues to consider, but the distribution impact, to my mind, is not a barrier. That's it.
Thanks very much, David. Apologies, I should have introduced myself. Alan Hurd, I'm head of economics here at the university. So let's open it up to the floor.
Dave, really interesting paper and not thoughts in my mind. But I suppose one of the things is this symptoms that you alluded to at the end, that the question of the heterogeneity in the population that you're looking at. That, you know, there's one thing to say, well, the good and the bad balance out. But the practice is that the negative effects are going to be pretty dramatic for some households. And I mean, you know, we can, you know, you could paint a cartoon picture of some household that Channel 4 might find to do a program, you know, and who would be devastated by this kind of tax, who, you know, said, geez, we're on substitution, we're on a substitute. So, you know, you give us a little bit of lump sum recovery, but, you know, you give us the average lump sum, and we're way sure the average. So
You're absolutely right. Your caricature family might have a strong taste for sugar-sweetened beverages and going to the chipper and whatever. They might eat any fresh fruit or vegetables. Sure, they're going to get hit much more than the average. The household that doesn't buy those foods but freaks out on fresh fruit and vegetables, they're laughing because they're getting those goods subsidised and they don't spend any money on the bad goods. So yeah, there's always that heterogeneity because these sort of taxes and even these compensation mechanisms are blunt. You know, they find it very difficult to get at address this heterogeneity. My guess is if the government was to introduce that, I gave the figure there of 28 million, they would quite possibly actually, they might even overcompensate to allow for that fact, so that the households that consume lots of those goods would be to some extent. But of course that would be an even bigger free gift for the households consuming fresh fruit and vegetables, for sure.
Thanks for everything. My question is, if you're concentrating only on, say, the financial effects of within, say, your caricature family, and you're talking about recompensing them, then aren't you negating the desired effect of getting them to move away from those kind of foods and make healthier choices? Or am I missing the point?
No, you're not. You're absolutely getting the point. But that's exactly what I said. This is, if you like, quite a narrow paper in its own way. This is a more narrow and deep paper in the sense that I try to get behind what the distribution impact would be, and I'm looking at it in terms of what the financial cost of the fat tax would be. But for sure, there would be health. Well, if it works the way it's meant to work, we would like to think there will be health benefits accrued. And certainly, you could extend this paper and try to put some sort of valuation on those health benefits. as you were talking earlier on, evaluation of maybe longer disability just life years, etc. And that would be something which you ideally would like to take into account, but that's kind of beyond the scope of this paper. I was just looking at the poverty effects of these packages.
Thanks for a fantastic talk. I mean, recently we've introduced water charges, which are effectively a tax for drinking water, and you know, a tax on property tax for living in your house, sort of thing. And it just strikes me that as this proposed tax potentially just taking that on its merits, while it's clearly not desirable that it has a disproportionate effect on poorer people, is that, I mean, when we introduce other taxes, it doesn't seem to be a barrier to introducing those taxes. Would you comment on that?
Well, like I guess, I don't really know what goes on in the mind of the Minister for Finance or senior officials in the Department of Finance, but I would presume that when they're looking at any form of tax change, they're looking at it on the basis of efficiency, equity, simplicity. There are all these principles of optimal taxation, and you'd like to think that they're taking those factors into account. So, for example, a property tax is efficient in the sense that it's quite difficult to shift your property, so the substitution elasticities are lower. It scores well on efficiency, may score badly on equity. The same is true. We don't tax food typically, although that would be an efficient tax because it's difficult to substitute away from food, but because it's consumed disproportionately by poorer households, it wouldn't score well on the equity index. That's why food is typically not taxed. So I think they do take these things into account. In terms of these types of taxes, I think that the reason why I like using the revenue neutral approach is that I want to get the fixation away from the revenue collection aspect of it. Because the idea of this tax, the same with taxes on smoking and alcohol, is the idea is we think there's a market failure. John talked about this morning. We think there's a market failure, and this is the second best way to address the market failure. When you combine it with the subsidy, then in a sense you've parked the effect on poor households. Leaving aside Brendan's perfectly valid point that there is heterogeneity, on average, if you've got the tax subsidy mix, on average poor households are not worse off. So it's not anti-poor in that sense. I hope that answers your question.
Thank you. Cliona Loughnane from the Irish Heart Foundation. And I suppose one of the things to say, David, is that we really appreciate that you are looking at things like the tax and the subsidy, because I suppose we've very interested in how healthy foods could be subsidised, and there seems to be a lot less research done on that kind of area than on the taxation area. So I'm just wondering, and again it might be beyond the scope of your paper, but in terms of your research, have you found any good models for how those kind of subsidies might work, or people who are doing research in that area?
Yeah, the answer is not really. And one of the slides I put up kind of points to note. These are the kind of things I wave my hands at a bit. And you're right, it is a big issue, this issue of incidence of both the tax and of the subsidy, that if you were to introduce a 10% subsidy, would producers just pocket that themselves and not pass it on? If you've got sufficient competition in the market, then the subsidy should be passed on because somebody else is bound to do it, so you'll have to follow suit. But if there was a cartel or an oligopoly situation there, then they might well have a gentleman's agreement not to pass it on, and you might have to think of other types of interventions to make sure that it is passed on. So for sure the practical implication of tax and the subsidy would be important. And I do know, I said I remembered the Matchstock Men song that Anne referred to. I'm also old enough to remember, I'm on the bit where the age squared is kicking in, right? I'm going right down that slope. I also remember we used to have food subsidies over a selected range of goods in Ireland. They were abolished, actually it was very clever, they abolished them the bank holiday weekend of 1983 when everybody was off sunning themselves and they thought nobody would notice. So we did have food subsidies in Ireland before, and it would be useful, I think, to go back and see how they were implemented and how effective they were in terms of bringing down the price. That would be the first place I'd look at if I was to research that in more depth.
Catherine Hayes, Public Health, Trinity College. Thank you very much for a fascinating paper, and I must say I feel very reassured by your findings. because one of the constant criticisms about introducing, in particular, say, tax on sugar-sweetened beverages, which is what really, I suppose, has been considered maybe most seriously for the present anyway, is of the disproportionate effects on the poor. So I think your work actually is very significant in terms of that reassurance, because, and also from the point of view that in terms of health benefits, the evidence around subsidies is actually a lot less convincing in terms of health impacts compared to the more punitive or the taxation. I suppose because it disproportionately does affect the poor, and maybe they are less likely to, eat healthier foods. But I think your work helps inform, what may be future policy, because there is no doubt that consumption of sugar-sweetened beverages, whereas it mightn't have direct health impacts in terms of weight and obesity, but it has huge impacts in terms of development of diabetes. Thank you.
Thanks. Not really much I can say in response to that. I make the broad issue of the sugar-sweetened beverages is something I was on a review group with Ursula there and others. We looked at this, and we had a very wide-ranging group, and there was a lot of really good work done analysing it. And there's pros and cons for sure. This just really looks at one narrow aspect, and as you say, I suppose, yeah, this is useful in the sense that if somebody raises that red herring, I think it's possible to come back and say, well, look, it seems pretty feasible to put together a package where there isn't any adverse effect on the poor. So I think that's useful.
Unfortunately, we're out of time. Apologies to a couple of school people trying to get in. So that ends that session. Thanks very much for all the questions. Thanks to Anne and to David for a great session. Thank you.
We just had about a 5-minute break if anyone needs to stretch now, and we get set up for the round table to close the conference. Thanks.
So I can bring the camera up here. There you go, man. It's all good. It's all good. Just, yeah, go on, man. I have a story. Well, I have a choice. It's not mine. No, there we go. Am I still streaming or haven't? Can you just check that I'm still streaming there, man? We haven't knocked down then. You have your skills, my friend, but cameraman is not one of them. Stroll, man. Yeah, you have to give me a bit. So you just picked exactly the wrong seat, but you're grand there. Thank you.
Yeah. And the one there. I think, I think we might get started. So maybe if you could take a seat, please. Great. And so thanks to everybody for staying for the whole event. The origin of this idea was that when Brendan Walsh had his Economics of Cancer Symposium last September, some of you were at it, Charles Normans did a fantastic job of moderating a roundtable discussion to close it. I don't know, do you know Charles, but he's a very tall, fine-looking man. I thought to myself, when I grow up, I want to be like Charles. So this is basically me practicing. And the other origin is that I think it's a useful way to close a program like this, to have a more informal chat. Now, so I'm just going to kick off with one specific question to John, because I know, John, we because of time we have to curtail your talk before lunch, and so. I suppose, of course, even though as complex an issue as it is, people are still kind of looking for relatively simple answers. I mean, Ivan Yates this morning, when you were being interviewed by Ivan Yates, he said, "Give me one thing." So your answer to Ivan, do you want to replicate that for people here?
Well, the short answer was there's no single magic bullet, and I think that rather there being a single fix, there's really a best approach, and the best approach should be evidence-based public policy, where it's okay to try new things, but you want to evaluate them and continue to make them better, and to the greatest extent possible, incorporate what we know from what's already been tried, has been shown to work and shown to work in the most cost-effective way. And that's something I didn't get to talk much about this morning, but the basic idea behind cost effectiveness, is Francis was alluding to earlier as well, is that when you have many ways of addressing a problem like obesity, you want to make sure that you spend your limited budget in a way that gets you the biggest bang for the buck, that does the most good for society. And when it comes to obesity, it's kind of the Wild West in the sense that lots of people are trying different things. Lots of clinicians are trying different things with their practice. Different schools are trying different things. Businesses, health insurance companies, governments. And that's an exciting thing. But we just have to be careful that we're not doing things that waste resources and that don't work. And so when I've evaluated things like school-based programs, for example, there's often been a fear of evaluation. There's a sense that, aren't my good intentions enough? Why are you hassling me? With all the bad guys in the world, you want to come measure whether what I do makes a big impact? But as hard as it can be, I think we have to turn that, scrutiny on ourselves and really measure to make sure that the things that we're doing work, and measure the cost associated with them and figure out what's the cost effectiveness of the approach and then compare it to other things and then share that information. So like I said, it's really this approach I think that makes the most sense, as opposed to one single magic bullet that we can take off the shelf that'll work everywhere.
Thank you, John. So the panel, as you can see, is John and Francis that you saw earlier, and then Tessa Greeley is the Director of Public Health in HSE Midwest, and Miriam Owens is from the Department of Health in Dublin. So Tessa and Miriam, we haven't heard from you yet today. Well, I don't mean that as a threat, but I don't know why. Tessa, you're if you want to call it, you're at the coalface. You're working. You're trying to maybe get a larger budget for public health for this problem. What strikes you out of what you've heard today?
Well, thanks for that. I'm, in fact, Anne D is the Director of Public Health at the moment because we rotated between us, so I don't want to take away your laurels from you. But we work together, and so we obviously have been working public health for a number of years, and a lot of the area I work with are in relation to children's services, child health and the environment. So there's a lot of relevance, to both of those areas in terms of our obesogenic type of environment. Things that really struck me today from, because I came here to learn, were that, first of all, there's absolutely no doubt about, the health impacts of obesity, the trend of increase over the recent decades, and the multifactorial background to it. So really there's no arguments about any of those. And the thing that one fact that John mentioned, I think that really came out to me was that it's only a very small knife edge really that makes the difference, over the years, that all it requires is this potentially 41 additional calories on average, so that really there's very little difference between the things that keep us on an even peg and then go on to incrementally change our situation. So, but that we therefore have got to, and the problem is we don't have any sentinel, we know when we're hungry, so if we have undernutrition, we're going to go out and eat, but we don't know for quite a while whether or not we're having too much until the pattern's established and it's harder to change it. And particularly because my interest in child health services, we did a lot of work in the Midwest in developing a personal child health record 10, 12 years ago, which unfortunately hasn't actually been rolled out to the rest of the country except in a few small places. And that that actually gives the tools to people, to families to have within their own hands the growth charts, and they're able to see, what differences are being made, and because in early years parents are very keen to see how their children are doing. It's only as time goes by that the encounters with health services are less, and then it's much harder to get that sort of sentinel impact about, do we need to do something? So I suppose the overall message really is, we are hoping to do something in Ireland about measuring weight and height in children at school entry, and to return to some of the measurements that were made. But apart from that sort of thing, and the more general use of child health records, and hopefully they will be rolled out as well, we need a multidimensional approach along the lines that Anne was describing, because it's a multidimensional problem. So.
Great, thanks, Tessa. Miriam, I suppose your role in the Department of Health might be more at the policy-making level. You want to, from that perspective, what do you think are the critical issues that will be discussed at policy level over the next short term?
Thank you, Brendan. While I am in the Department of Health at policy level, I'm also a public health specialist, so my interest is from the health side. My work involves working with Healthy Ireland, which some of you may know of. It's a health and wellbeing policy framework that was launched in March of last year. And while obviously the topic here today of obesity is very central to this, obviously we're looking at lots of other lifestyle risk factors that are impacting on our health and wellbeing, and that we are trying to address in the 4 goals of Healthy Ireland, 2 of which are quite relevant and have been mentioned here today. One is to reduce health inequalities, and the other is to help people to live long and healthy lives. Obesity results from a lifestyle behaviour, as does the consequences of physical inactivity, smoking and excess alcohol consumption. And all of these problems are multifaceted, so they're going in their causation and they need multifaceted solutions. So with Healthy Ireland, we are trying to bring about a whole of government, whole of society approach, and engaging other sectors of government and other sectors of society where, in fact, many of the solutions lie. Because by its nature, the health sector is working in dealing with the consequences of ill health rather than the prevention in a traditional capacity. So, for example, the Department of Transport and Education have key roles to play in how we live our daily lives, how we move, how we play, how we interact with our environment. Department of Education is a key role in helping children to not only learn the traditional 3 R's, but also to learn how to be, healthy and active people as they grow into adulthood. So from a policy point of view, we're in the early stages of Healthy Ireland. We won't have any quick fixes because unfortunately, as the WHO has called a lot of these problems, they're wicked problems. Some of them we don't know what they cause, so we have to find what's the solution. So from a policy point of view, we are trying to look at how we can engage not only government but society, but the combination of the top-down, bottom-up approach, because at the end of the day it's often easier to sort of build a healthy, happier, more active and fitter community than it is a country. So it's the building from the bottom up and the top down. It's where we're at the moment from a policy point of view.
Great, thanks very much, Mariam. So I'll open this to the floor now for any questions to any of the panel or any comments. Faheen, who is doing a marvellous job with his roving mic. Is there Anne here in front, Faheen? Thanks.
Hi, I don't really have a question, but I just want to kind of synthesize what I've been thinking over the day, and just at one point we saw slides showing, the change in infectious diseases and chronic diseases, and it was attributed to public health that infectious disease has been controlled more or less. And I think now our role isn't simply in the control of infectious diseases, but our challenge for the next 100 years is the control of chronic disease. And I think I see this very much as the main task facing public health. I think it's not as simple as maybe controlling infectious diseases was, but even for infectious diseases it was multifaceted. It was sewage, water, vaccines, better housing, better education. All these things contributed to the control of infectious diseases, and in the same manner we need to have a multifaceted approach to the control of chronic disease, and the prevention of obesity, tobacco and alcohol consumption are the key pegs really in this, and the promotion of physical activity. Various things were said during the day, like people optimize their utility, and they make their choices. But I would see it that especially for poorer people, maybe less well-educated people, that first of all, I think that there is an element of addiction which hasn't been mentioned today around the whole consumption of sugar-sweetened foods and fatty, tasty foods. I think there is an element of addiction which can't, fit into that optimizing kind of theory. But also, there certainly isn't perfect information. If there was perfect information, then people would be fully aware of all the consequences of everything they put into their mouth. And again, I think that can't, it's just not the case. And Brendan Walsh pointed out a very effective way of preventing childhood obesity. Get yourself born into a family that's rich, that's posh, and whose mother is very well educated, and you're sucking diesel basically. But apart from that, again, that's not something that's within the child's control. And so I really feel that there has to be a push
for regulation from government. I think that we've seen there is huge evidence that taxing tobacco has caused people to reduce their consumption. There have been other elements like educating people about the effect of tobacco since the whenever Dahl and Hill did that, was 1960s. We've seen tobacco consumption come down and down and down. It's more difficult with alcohol, but certainly the evidence would show that increasing taxes and bringing in other regulatory measures does have the effect of reducing consumption. And so while there is not a lot of experience to base it on, I think we could consider that it is likely that we could move people away from consuming things that are not good for them by introducing fiscal measures. And as David pointed out, I think that's, that could be recompensed. The regressive nature of that could be recompensed to poorer people in some fashion. I think we need to have, as public health professionals, a single voice with a simple message. And I think we need to shout that very loudly. And I think we need to, Kieran here beside me always tells me when I'm complaining that the way to eat an elephant is one bite at a time. And I think we need to take our bites one at a time and make it very clear what our message is, and then add another simple, clear message to that when the time is right. And I think that needs to be our approach if we are to be able to say in 100 years' time, remember back in the 2000s, imagine diabetes was 5% of the population or whatever. So that's all I have to say.
Thank you, Anne. That's interesting. Miriam, yes?
Thank you, Anne. That's very concise summary of today and very good points. I'd just like to say that today's gathering, I think, has shown us all, in those of us in public health, how we're all looking at the same problem from a different lens or from a different angle. But I think it's the collective work that we can all do together is what's going to help here, because what's needed, over the years, people know fat food is bad for you, people know that, but people are still smoking. So that's one element. But I think we have to see how we can actually change behaviour, and pooling together a lot of the sciences here between, behavioural psychology, public health, health economics, to see exactly how we can do that. How, as someone mentioned, the choice architecture, how we can change how we present food, especially to children, because, our children, they don't know any different when they're very young. And if we make things easily available for children, and I think at the moment you may have seen the Safe Food and Healthy Ireland campaign on television about the portion size and all that. Like, part of that campaign is about how we can actually help parents to help their children to make the healthy choice. Because what's come out of that campaign and the focus group work that was done in advance of it was that parents, they do know they have a problem, but they're looking for some help, something very tangible to help change both their behaviour and their children's. And I think a forum like today has really, I think it's bringing a lot of collective people together. So, let's do it again. Let's have another meeting of minds, a meeting of ideas, and set up some sort of a network or something where we can learn about each other's work and see how we can work together. And from a policy point of view, I think it would be very interesting to have an awful lot more people like this working with us.
So I see a couple of hands, but I saw Dave's first. It mightn't have been the first, but it's the first. I saw Molly, I see yours as well, and I see Eamon's, and I see other people I don't even know. So Dave,
okay.
Right.
Well, okay, so everybody's agreeing with each other too much here, so I'm going to throw something into the pot. How do we know what the optimal level of obesity is? Is it 0? Is it 10? Is it 12? Is it 15? Is it 25? How do we know what the optimal level of smoking is? Is it 0? Is it 10, 15, 85? How will we know when we get the choice architecture right? Is it choice architecture that architecture which produces 0, or which produces those other numbers that I've mentioned? I get the feeling that we all think that we're in a situation which needs improving. And maybe that's all we need to know for the moment, that we can move towards a better situation. But I suppose I'd be interested to know what people's views are on what the optimal situation would be. I suspect an economist's answer might be different from a public health specialist's answer.
We'll get two, so Dave, thanks. John,
so to give the economist answer. So I think that's a great question, because it makes you think about why is it that you're objecting to current levels of obesity. And I think it helps people tease out like whether they're sort of subconsciously being puritanical and trying to control other people's lives. But I think the answer from the point of view of economics would be that the quote-unquote right level of obesity is that which exists when people are making decisions with full information. They're not imposing external cost on anybody else. They're not plagued by time inconsistent preferences where they can't commit to the healthy path they want to lead without being sort of impulsively driven to consume in ways that are sort of in violation of their long-run well-being. And then wherever those chips fall, that's the quote-unquote sort of optimal, socially optimal level of obesity. But I would guess it's highly unlikely to be zero, and it may be higher than maybe certain activists would be comfortable with. But at that point, people are making rational decisions as fully informed people, and who are we to question that? So that's one perspective.
Francis, could I get yours on that, please?
Sure, yeah, I think it's a great question, important consideration. I guess it depends on what obesity is. And if obesity is a high body mass index, then there's a proportion of people with a BMI above 25 or above 30, whatever threshold you use, who are absolutely healthy and fine and don't necessarily need to lose weight, in fact. If obesity is, having so much fat that you develop insulin resistance and diabetes or arthritis in your knees or sleep apnea syndrome, or you shorten your life expectancy, then I think we'd have to have a zero tolerance of that, or aspire to nobody being unwell from excess fatness. Does that answer the question at all? No. Yeah.
Molly? Sorry. Yeah.
Thank you. Molly Byrne from NUI Galway. So I don't mean to cut across this potentially interesting discussion here, but I'd just like to say that I'd agree with Miriam's point that I think it would be very important to create this kind of a forum. But I suppose I'm just aware as a health psychologist that I think health psychology and behavioural science has been missing from the discussion today in terms of developing effective behaviour change interventions. So I would just like to raise that. It's not a question, it's really just to add to the forum of expertise, I think, within the room. But congratulations on an excellent conference anyway, Brent.
Thank you, Molly. So, Eamon, you're just nearby there, and I see your other hands, yeah.
So it's just kind of a related question to do with employers. I was just wondering why the panel think that employers don't do more about this. Given that presumably this impacts on absenteeism and productivity and so on, to what extent do employers should bear some of the costs of this in relation to productive workforce in terms of, and again it's a related question of how much would they do, should they do in the context of their cost-benefit analysis of whether this is an issue for them or not. So
I mean, just to add, John, because I know, for example, one of the things that the US military is very concerned about at the moment is suicide, because it's affecting them, and so they're funding incredible, interesting research in that. Is there any sign that you were talking about the military being affected by the levels of overweightness, that they're interested in, if you like, tackling the problem at an earlier stage?
Oh, absolutely. So there's a coalition of retired generals and admirals who have formed an organization called Mission Readiness. And they are strongly advocating for better food in public schools and stricter physical education of children, because it's their perception that rising obesity represents a threat to national security, because so many children this next generation are overweight or obese that they wouldn't make good soldiers. So again, you may not feel that that's a problem for a certain perspective, but it does show the extent of the problem. And we have a paper that's coming out now that shows how the number of people who are eligible to serve, even in the U.S. Public Health Service commissioned corps in the U.S., so there's a uniformed service that's the Public Health Service, and they get deployed in the wake of a tornado or a hurricane. They go to Native American reservations and other underprivileged areas, and they provide direct services. And the number of Americans who qualify even for that has been going down, because they too have weight and height restrictions, body fat restrictions, because of the deployment possibilities. And so even fighting obesity has become harder because of rising obesity, which threatens to make this a self-perpetuating cycle.
But on the employers thing, I know that a lot of the literature seems to suggest that if it comes to general training, that it's not in employers' interest to provide or to subsidise general training, because if it's general training, this is a skill which could be used in other jobs and somebody will just move off, whereas if it's specific training to that job, the employer will invest in it. So if one thought about the loss in productivity rising from obesity is a loss in general productivity as opposed to for specific tasks, that would be a rationale why employers would underinvest in what would be the socially optimal amount of investment to try and make their workers more healthy, because they may not reap the full rewards of it. That's just a speculation as to why they may not do as much as we think they could or should.
Yeah, Miriam, of course.
One of the goals of Healthy Ireland, as I said, is looking at how all sectors of society can work together, and we're talking with cross-government departments and with the HSE as to how we can look at the workplace as an area where we can address some of the risky health lifestyle behaviours. And from the HSE point of view, in their service plan for this year and their operational plan, the whole sustainability of the health service in terms of its resources and its workforce is being used as a vehicle where we can see how we can help people in their work, because most of your day you're spending in your workplace. There's a huge knock-on effect if a worker suddenly embraces the healthy living, the family, and the domino effect that can happen throughout society. And we are looking at in the Department of Health itself as how we can, with one or two other departments, do up some sort of a module or a plan or a template that we can transfer from one department to the others to see how we can signposting where the stairs is, first of all, things like that, because most big departments and most big buildings, you can't find the stairs for love or money. You have to go, you're forced through the lift.
I know there are a couple of hands up, but just listening to that reminded me that I know there's been work being done at UCC on large-scale workplace interventions. And I know there are some people from UCC here. Does anybody want to mention those, or do you want me? Okay, great, because I just thought it was, I heard Ivan talk about this 6 weeks ago, and I thought it was an interesting example. So great, thanks. And I don't worry if you have your hand up, I'll get to you.
Yeah, we're currently involved in a complex intervention with 4 different large workplace sites in the city and county, and it's we're currently just at the kind of 9-month follow-up phase, so the baseline work has been done. But it does look as, the catering industry from a workplace point of view are very open and very willing to work with health professionals. In one part of the intervention is, somebody mentioned in one of the presentations earlier on about the nudge, and it's changing the environment within the catering and within the canteen sector. So the research team, not me personally, but the research team led by Fiona Geeney, they've worked with the catering managers. They've totally reformulated all of the foods, all of the menus, and they've worked very closely with them in terms of reformulating the menus to reduce fats, sugars and salts. And we've had very positive feedback from the caterers in relation to that type of information or intervention, and from the workforce as well, to such extent that it's in 4 specific work sites, but some of the work sites have approached us to expand it to some of their other work sites as well. So I think within the workplace intervention and workplace health promotion, particularly from our experience, that workplaces are open to working with us.
Thanks. Tessa, sorry, you want to come in?
I was just going to say something along those lines as well, about also how sometimes private sector type organisations can have been doing things like that, and sometimes it's easier with a specific entity where you're managing it yourself and it isn't a very large organisation. It was just that I read a workplace report from a place where my son did a work placement during last year. It's a multinational company, where he did something, and a thing from college. So there was quite a lot there about what they had done to, the occupational health department had got these targets. But it the most funny part of it was that the management team had been challenged to do something, and they described how their away day, their annual away day, which was normally expected to be a golf or a sort of sedentary type of activity, followed by fine wining and dining, had been substituted unexpectedly. The day before, management team were called in and were presented with their tasks for the following day, and they had engaged to do a one-day clear-up of an aid centre in the area, and they were given their different tasks, their paintbrushes, their overalls. There was a management group who did the catering, etc. And so they spent the whole day working and producing something, as they said, doing a good day's work for a change. Wow. But it was sort of leading from the top, and I think that there's an element of that too, isn't there? That everyone says, "Oh yes, we must do this," but yet it is important that the people who run the organisation should actually show willing and and give a good example, and I think that was one that did.
Now, let me get to, there was a man down there, and then there's another, and then, yeah.
Thanks. I'm Chris McBurdy from Strive Clinic here in Galway. Just congratulations first on a great conference and very good talks all day. I just want to make a quick comment on a couple of things that were touched on, and then I have a quick question. Just to touch on Dr. Finucane, you kind of mentioned jokingly about the prime time debate earlier on in the week at the start, and Dr. D had mentioned in her talk just about agreeing a message and communicating the message, and just again there now about how healthcare professionals need to have a single voice and a single message. So if you look at say for example, the October 2013 NICE guideline on management of childhood overweight and obesity with comprehensive lifestyle weight management programs, they have kind of 4 key elements of, reduce junk food, promote healthy nutrition, reduce sedentary activity, and increase activity, essentially, with access to medical and psychological services if required. But if you look back at that debate a couple of days ago, it was really focused on sugar, junk food. And just the point I want to make is, following a Twitter feed that night, the overwhelming theme of what people were tweeting about watching that primetime debate was the 2 doctors there clearly can't agree on what is right, so how am I meant to know what to do? So my question is, what practically is being done in Ireland to agree some sort of consensus on what the message should be, and how would you suggest that we effectively get that message across? Because I think debates like that really aren't helpful for the general public trying to figure out what to do. Thank you.
Thanks, Chris. It's a great question. I think there are legitimate areas of uncertainty in the whole area of how we address this problem. For example, the issue about whether or not we should introduce an arbitrary precautionary sugar-sweetened beverage tax, and that's what it would. There are loads of limitations to doing that. There are pros and cons. That's just an example of an area where there's some legitimate controversy, okay? And that's just the way it is. It's a complex issue, it's a societal issue, it's a political issue, it's not just a physiological sort of clinical public health issue, From a medical point of view, from a public health point of view, I think it's a no-brainer personally. And I'd like to see it introduced, but I understand that that's going to be unpopular with the population. They're already taking other hits, and it certainly has a bad reputation. The concern I have in relation to, say, for example, the discussion on Monday night's prime time, is that there's undue influence from stakeholders like industry in making this decision. So you should listen to doctors about what to do. You should listen to the food industry about what to do. But ultimately, it's a political, social decision, and that should be made in the best interests of the population, and that should not be influenced by professional lobbyists who are paid millions of euro to influence policy. So I don't think necessarily we're making these decisions in the best interests of the population. That's my concern about this area. because a lot of us have been lobbying to get this through. You know, the Irish Heart Foundation had their excellent meeting last year. You know, the economists are doing their thing, the technical excellence in terms of assessing this, insofar as you can be certain about the effects. The due process has taken place. And yet, you know, 3 days before the budget, or the day before the budget, whenever it was, the Sunday Independent or one of the big newspapers leaks that there's going to be a health-related food tax introduced by James Riley, and then it's scuppered the day before the budget. So that's what happened, and I'm concerned that that wasn't in the population's best interests. And there's also an argument to be made. People say, the economists were saying, maybe they're right. They say hypothecation is bad, and what that means is saying you're going to take money off people who eat too many crisps or chips or drink too much sugar-sweetened beverage, saying you're going to take that money and then invest it, say, in subsidising healthier eating, paying off the troika, or developing bariatric services, which themselves are cost-saving. I mean, it's a win-win situation, I think, but I would say that. You know, if you don't ask a barber if you need a haircut. So, you know, there's all these people have their different perspectives on things, and mine is just one perspective, another. But you know, it would make sense to take that money and to I think, and I'm losing the point here, but the point is that shouldn't be influenced by, you know, you shouldn't put Dracula in front of the blood bank, in charge of the blood bank, and I think that's what we're doing to some extent.
Barber to Dracula, I don't know which is what. Miriam?
Thank you. I just want to add a little bit to that. I think also that we have to, you know, remember that, you know, media, it's there to entertain as well, so I think we have places like this where there's a good forum and very good factual debate going on is probably a better informative place for us. And as Anne said, we should have the, you know, the simple common messages. This Department of Health is obviously part of a full government, so, you know, things do get changed when, you know, it would be nice to have a hypothecated tax and all that, but it doesn't mean we've stopped looking at this in terms of the tax on the sugar-sweetened beverages. And the Special Action Group on Obesity, which the Minister for Health chairs, part of some work of that, and my colleague Ursula Dwyer here in the audience is responsible for a lot of this. Last year, during the EU-Irish presidency, an EU action plan on childhood obesity was proposed, and that is going to be published in the next few months, and Ireland has taken the lead on that. And some of the key points coming out of this will be, you know, supporting the healthy start, so encouraging breastfeeding, reducing marketing foods to children, increasing physical activity, and making the healthy choice the easy choice, which are the things we're talking about here, and they're the sensible, you know, first step approaches. So I think there is a lot happening. We get scuppered at times in what we're doing, but, you know, we continue because, you know, one of the goals is to improve the health of our population, so we have to keep trying. And as I said, you know, a lot of the media is for entertainment.
Okay, there was a person down here. Yeah, thanks.
Hi, my name is Teresa Corbett. I'm doing a PhD in psychology and health. I don't really know if this is a question you can answer or not, but I was just wondering about people who seem to resist these efforts, or people who see the carrots as bribery or the stick as punishment or nudge as nanny state, or even people who just put their head in the sand and don't want to talk about it, who don't know what their BMI is, who don't really care. Like, is there any way that you've come across that we could, you know, win those people around, or is there any opinions you have on that? Be interesting. Thank you.
So a couple of years ago, I did a survey of, like a nationally representative survey of the U.S. and asked people questions about their support for different anti-obesity programs, and then I also asked them about their sort of political leanings and their beliefs about where obesity comes from. Do they think it's genetic or a moral failure and things like that? And you're absolutely right. There is a certain segment of the population that thinks that is just opposed and thinks that the government intervention is a form of a nanny state, or that it's just not anybody's business what I decide to eat and whether I decide to be active. But even still, there was surprising variation in the amount of support for different public policies. And so it turned out that the least popular public policy was food taxes, that just, you know, adults were, I think they were really fed up about paying taxes in general, and then on top of that felt like it was a violation of their consumer sovereignty. But the most support was for interventions to help children. And this may go back to some of the points that Andy made earlier, which is that I agree that dietary and physical activity habits are sort of habitual, or if you want to use a stronger word, addictive. And so even people who seem to be opposed to food taxes, opposed to being told themselves what they should eat or how they should be active, were in support of improving school meals, making kids more physically active, subsidizing facilities for children like parks. And so I think, that's one potential way to go, is do more of these surveys and get a sense of where is there the most agreement. And I think sometimes, advocates guess wrong. So like in the US, advocating for a soda pop tax was quite popular for a while, and it was seen as like the easy, thin end of the wedge to get under the door, because it's empty calories. How could people be opposed to taxing it? When in fact, based on the survey, that was like the least popular thing to start with. And so maybe getting a better sense of what people are most sympathetic to and starting with that would be a good strategy.
Thanks. What would you say? Yes, here, please. Yeah.
Genevieve Becker, independent health researcher. I spend most of my time with health people, so it's been very interesting today to interact with economists and so on. And my query is back to some of the economic issues of health. We've heard today a lot about the costs, the economic costs of obesity, but to also look at their economic benefits from obesity, that we need to balance out with that. And it's how do we balance this? As Dr. Finucane alluded to there are lots of people employed in treating obesity, in treating illness. There are hospitals built, there are services, there are goods. If we were all thin and healthy, all those people would be unemployed and that money wouldn't be being generated and that economy wouldn't be there. Ireland has a large economy in producing and particularly in exporting obesogenic foods, particularly to emerging economies, with government supports, taxpayers' money, in increasing this economic activity in Ireland to provide higher levels of obesogenic food sales in emerging economies. If we reduced that obesogenic food exports, we would increase unemployment. That when that's brought up with the Department of Health as this is a conflict between government departments on what they're supporting, the reply I got was unemployment is as unhealthy as supporting health. So from the economic point of view, where do we go in balancing the economics of illness in generating income as distinct from the economics of good health?
So that's a really interesting point, because it reminds me of, I guess the distinction I would make is that there are people earning profit and there are people whose occupations involve like obesogenic activities and products. But I wouldn't say that there are economic benefits to obesity, and it kind of relates to this actually debate from like 200 years ago about, is war good for the economy? And so the argument was, well, actually it started during the Napoleonic War, is that people would observe, like, well, look at all these soldiers, they pass through a town, they buy all this stuff, all these people had jobs, armaments manufacturers are making stuff, war is good for the economy. And so there's sort of a classic economic essay called That Which is Seen and Not Seen, which points out that war is not good for the economy, it just uses up resources in a non-socially beneficial way, but we think it helps the economy because it's seen, right? You can tangibly see the soldiers, you can see the cannons and the guns, but that which is not seen are all the jobs those guys would have had as farmers had they stayed home and not been forced into the military. You don't see all the economic activity that would have happened if all the taxes weren't levied to fund the military. And I think something true is going on here, that doctors wouldn't be unemployed, they'd just be treating other conditions, and that would be good for mankind, right? We could go after other priority conditions than obesity. So that's the distinction I'd make. I don't think any obesity is in any way good for the economy, but certainly there are people earning profit from it.
Sorry, Diarmuid, and then, all right, Diarmuid, yes.
Okay, I'm Diarmuid O'Donovan. I work in public health in the HSE and in NUIG. Just on war as well, just a comment. At the beginning of the Boer War, there weren't enough fit, poor young men to become soldiers, so the welfare state was I believe a large part of how the welfare state developed was to feed young men to produce healthy soldiers. So we may be seeing something like that starting to happen again. But just the wider thing I want to talk about, the whole thing about obesogenic environments, in the context of, for instance, the Horizon 2020 research call that's going to be there for the next several years. Core part of that is, climate and sustainable development is in it across every sector. There's the rhetoric around sustainable development and inequalities in health is in Healthy Ireland and in multiple policy documents in Ireland. But it could be, from a university point of view, that we need to start thinking about putting sustainable development at the centre of every single sort of thing that we need to do, and thinking about obesogenic environments through to bariatric surgery, the links all the way across. What Tim O'Brien said this morning about the generation that's going to have, where parents are going to be burying their children because of obesity-related disease. I mean, it fits right in with that whole argument. So maybe we need to just start doing this sort of thing that brings many people together. We need to do much more of it, and going back to agreeing with the people who've made those points.
Thanks, Damon. I'll just keep going because I know there's a question here in the front. Thanks. No, sorry, here first anyway.
It's Joe Connolly. I have a question for Francis maybe. I'd say if you were diagnosed by a doctor, say you are obese, that the immediate reaction would be scared, and you'd say, how did I get to this and what do I have to do? But in John Cullinan's paper earlier on, is this the Irish kind of that said that nearly 90% in the self-reported health were asked to rank their health that were obese, and 90% said they were either good health, very good health, or excellent health. So, if that's the facts, Francis, the people that go into you that are obese, do they realise the danger? Are they very unhappy? Are they scared? Or how is their mental state?
Yeah, well, the people we'd see, Joe, in clinic would be at the tail end even of that group of patients, so not just people with obesity, arbitrarily defined as body mass index above 30, of which 23% of the Irish population are obese, but it's the sort of 2% that we see, the people with a BMI over 40. So I saw a guy last week, he's 177 centimetres tall and he weighs 217 kilograms. So he should weigh about 77 kilograms. So he's 140 kilograms overweight. So every time he stands up or gets out of a car, he's effectively squatting 140 kilograms. That's more than most guys in the Irish rugby squad would squat when they train in the gym. So it's amazing that he can even get out of his bed in the morning. But so we're talking about very severely affected individuals coming to a hospital-based service. And part of the reason for referring them is that they have to want to lose weight. They have to need to lose weight, and then they have to want to lose weight as well. And otherwise, there's no point in sending them in. So, yeah, the patients we see are highly motivated to lose weight, and they're frightened about it. Yeah.
Yeah, could I just make a comment? It seemed to me, I know it was just a cross-tab, John, in your paper, but it seemed to me that number that Joe has cited, it undermines the idea that we're rational about our health. That you've so many people who are obese who think their health is good, or very good, or excellent. Even just, I know. I think for any economist, if you're neoclassically trained at all, it's always a struggle to say, okay, at what stage do you say, to hell with it, people are not being rational on this. But it just seemed to me that simple statistic that you showed. Now I know that when you did your fancy econometrics, it doesn't seem quite as dramatic, but still, I just felt like Joe did, that it was a really striking number. Do you want to say anything on that? Or?
Yeah, I think I said during my presentation, I was a little bit surprised initially when I ran the cross-tabulation that it was 22%, I think, of obese mothers in the sample rated their health as excellent. Now, I was a little bit surprised by that, but then we have to be a little bit careful in terms of, the classification of obese in that. It's a BMI of over 30, and maybe there are actually people in the sample who have a BMI of 30 or a little bit over who actually are in excellent health, so it's fine. The other issue in relation to those sort of subjective self-rated health measures, and this is something I spoke to John a couple of days back about, was, if you ask an Irish person how are they, I'm grand, I'm good. And the analogy, or the story I said to John is that, when you ask an Irish person this, they may have just written off their car, but they're still going to tell you they're grand, or they're fine, or everything's great. So, yes, there is an issue in relation to these subjective or self-rated measures of health, and that would obviously be something that would need to be discussed and thought about, in more detail in terms of the study that we're doing. But I think it's important to note that you can still have good health and be overweight and obese. And another issue that we're going to look at a little bit more detail is further to the right in that BMI distribution, and particularly, people who are approaching, I suppose, Francis's, study populations in terms of, I think if you ask someone who's morbidly obese, how do they rate their health? I think we haven't looked at this data, but my guess would be we would see very few of those, rating their health as excellent or very good. I think Dave wants to say a couple of words on this as well.
Yeah, it's just with respect to the self-assessed health measures. I've used them myself and I've defended them, so I'm in favour of using them in research. But I suppose with any self-assessed type measure, and this would apply particularly to these measures of subjective well-being, but I think it might have a relevance to a measure of self-assessed health, is that you can have a phenomenon known as adaptation. So it's possible that somebody could their BMI could gradually increase, and it goes from, let's say, 24 up to about 28, 29. If it happens over time, they may still be happy enough with their health. They may be happy enough with their BMI, in the same way that when they ask people who are in wheelchairs about their subjective well-being, they'll say it's okay, but that doesn't mean that we would all like to be in a wheelchair, or we would all like to have a BMI of over 30. So there could be some process of adaptation going on. The other thing is that there can be systematic differences in the way that people self-assess their health according to their nationality, according to their age. People use vignettes to try and get around this, but as John said in his presentation, the self-assessed health measures, they do tell you interesting information. They are good predictors of subsequent mortality and morbidity, but they come with a health warning as well.
Okay, and I see your hand, but I just want to check anybody else who hasn't commented already. Oh yes, sorry, there's one person there, and I'll come back to it.
Hi, Marie Casey, HSE Midwest. What I just thought about there is about definition of health, because most people would define themselves as quite healthy if they're not, they don't have cancer, they're not in the hospital, things like that. So I think that's really important too. Like, what about asking questions such as, are you confident you could walk a mile, or things like that?
Good question.
Which is the
longitudinal,
whatever it is. Anyway, they do ask exactly those things, like there's information on how hard you can squeeze a tennis ball or something like that. So yeah, there is that objective information.
But just one quick sentence. That's exactly the point. Fitness is a far better predictor of how well somebody is than body mass index is. When you look at fitness, body mass index disappears as a meaningful index of how healthy somebody is. So it's a much better measure.
Oh yes, sorry. Yeah.
Just a follow-on comment to that. When you look at risk factors for disease, being sedentary is actually below obesity, I think, in the WHO paper on that. And I think what's interesting is that a lot of the focus is on obesity and exercise in relation to weight loss, rather than just saying, actually, you know what, you might not be normal weight, but actually, if you exercise, that would be great. That would be better than doing nothing. So.
Absolutely, no question.
I see.
Behind you.
Hi.
Oh, yes.
Hi. Sorry.
Yes.
Catherine Hayes, Public Health Trinity. Just, I suppose, on the debate and about BMI and all of that, I think it's important to remember that obesity isn't a uniform thing, and it's actually central obesity, which is actually the really big problem. And waist circumference is a much more sensitive measure than BMI, because it is that central obesity that puts pressure around those central organs of the body, the heart, the liver, the lungs, etc., that really is responsible for the excess morbidity and mortality due to obesity.
Thank you. Any other comments? Because we're right up to time, and I know people are anxious to go. So I'll just say, I'll just leave it at that then, and I'll just say a couple of things. One is to thank all the speakers and the panel for their fantastic presentations throughout the day. They were really excellent. They were better than I could have hoped for. I suppose a special thank you to Professor Cawley for coming all this way, and it's been a real pleasure for us to host him for the last few days. And to thank all my colleagues who helped out on the background stuff. They're mentioned in the notes, but Professor Kieran O'Neill and Eamon O'Shea were really helpful in funding this event. And also to thank Imelda Howley, who's gone home earlier, and her colleague Claire Noon for doing all the administrative work. You know, I really take on board what Molly said in terms of trying to, you know, drive this forward. You know, I mentioned earlier Brendan's excellent symposium last September, and out of that has emerged an economics of cancer group. So, you know, it's great to see such interest in this area, and you know, I think there's such a body of people in NUI Galway, economics, psychology, medicine, other disciplines. I think there's going to be a lot more events like this here in the next couple of years, and we're really looking forward to that. And to finally just thank all of you for participating. Thank you especially to the people who travelled long distances to get here. And just finally say that the proceedings, thank the tech people for recording them. They're going to be available on the a YouTube channel that you'll find on the Cairns NUI Galway or NUI Galway Cairns website, and as and when we get the slides for the different presentations, we'll make those available there as well. Thanks very much, and safe home.